So when we're talking about doing a health history interview for the GI system, you're always asking questions about genetic history, genetic considerations. There's always a box in your assessment chapter that goes over certain things that are considered genetic components of each system. So make sure that you review that. One of the other things is, you always want to ask the questions. There's a list of questions on page 570 in your textbook, but some of them when we talk about GI, nausea and vomiting. When they are vomiting, what does it look like? Does it look like coffee ground emesis? That can indicate old blood. Is it bright red? Constipation, diarrhea. There is a whole list in the back of the assessment part of different questions you can ask to assess characteristics of stool. Believe it or not, my family we're all about poop. So they were not overly put off about when I was a GI nurse, and that's all I constantly talked about. But on the bright side, you really can learn a lot about what is going on with somebody's body if you're looking at the stool. It can tell you many different things. For example, you can have black tarry stools, which is called melena. You can also have stenatoria, which is considered those yellow, frothy, kind of greasy looking stool. This is actually occurring because of fat malabsorption. You can have some kinds of odors to stools. GI bleeds are really the biggest one that has a very distinctive odor to the stool. You always consider dark blood old and bright blood something fresh and new. Consistency of stools is also something that you want to know. If you have a patient who's constantly having constipation, you want to kind of ask some questions. Do they take laxatives? What kind do they take? What works? What doesn't work? And then you may have to ask further questions about the stool itself. So when we also are talking about questions and asking questions in regards to the GI system, and we talk about nausea, vomiting, constipation, diarrhea, but we also want to ask the patient if they've had any kind of recent travel. They have went overseas and picked up some type of a parasite that could be causing some of that nausea, vomiting, diarrhea type symptoms. Dietary changes, any onset of lower abdominal pain. Left lower abdominal pain usually indicates diverticulitis. And then rectal pain, they could have retained stool or they may have hemorrhoids. So those are just a few of the questions that you can ask regarding the GI system. Some of the other things that you can also throw in are age-related changes. Make sure that you always review those boxes. You can also ask, a lot of times patients have a lot of chronic heartburn type issues, but you want to make sure that when you're asking the questions, you're distinguishing the heartburn versus chest pain. You also want to keep in mind that when we talk about abdominal pain, there's often referred sites. So they could have abdominal pain and then they have pain in the right shoulder, which is usually indicative of the liver. A lot of times they also can have the right upper quadrant pain. That's usually your cholecystitis. So when we talk about the GI diagnostic type test, we're going to start on page 571 and we're going to look at the barium swallow. The purpose and description of this test is you're trying to diagnose esophageal varices, inflammation, ulcerations, hiatal hernia, sometimes a foreign body that may be dislodged, diverticuli, or tumors. And when we're thinking of doing the barium swallow, we're focusing in on the esophagus, the stomach, and the duodenal bulb. What happens is the patient has to drink about a 20-ounce chalky, liquidy drink. They used to not have flavors, but I think now they come in different flavors like banana and I think some kind of a citrus flavor. But it's nice and thick and white. It looks like really thick milkshake. it doesn't taste like a thick milkshake. What it is, it's actually barium sulfate for the most part, and it allows the X-ray technician to see those components of the esophagus and the stomach kind of light up or illuminate on the screen because the patient has drank this particular drink that allows that to become more visible. So some of the things that you need to know as the nurse is that you need to instruct the patient not to eat or drink or smoke 8 to 12 hours before the test. The patient cannot have any narcotics or anticholinergics for 24 hours prior to the test. We don't want to stimulate anything in that gastric area and sway our test. The other thing is following the test, the patient usually has to get rid of the barium out of the system. They need to usually take a laxative and also encourage fluids because we don't want that barium to stay in there. That barium will become like concrete and they will end up with an obstruction. So that is extremely important. There's also a picture, I think, on page 571 in your textbook, so you can see the barium in the stomach and how it's lit up on the x-ray view. The other test that we're going to talk about is the endoscopy, which is on page 572. It's the upper endoscopy, also known as the EGD. So when we're talking about the upper endoscopy or EGD, we are visualizing the mucosa membrane lining the esophagus, the stomach, and the duodenum. This is where they stick a flexible fiber optic scope in to visualize any kinds of varices, ulcerations, inflammation. They're taking video imaging of the stomach and taking pictures. These little fibroscopes have little pinchers on them so that if they get in there and they need to take a sample, that they can extract some tissue and take a sample. The other thing is that you do need to know that if you schedule this test, it needs to be 2 days after a barium swallow or an upper GI system, because you have to give time for that barium to get out of the body. You would remove any dentures or eyeglasses. The patient can have any food or drink 6 to 8 hours before the test. It usually does not take very long to do an upper EGD. They actually can do an upper EGD in a physician's office. They don't have to go to an outpatient site. But you need to know that they'll have a local anesthetic. They usually administer some kind of throat numbing medication. The patient is allowed to eat or drink as soon as he can swallow safely. Remember, anytime we are going down the patient's nose or throat, we need to make sure that you establish gag reflex before you give them medications or food or fluid. So you need to tell the patient they may have some mild bloating, belching, flatulence after the procedure. That's normal. Tell the patient to contact the physician. However, if they have any epigastric pain, shoulder pain, vomiting blood, fever, and if they have any difficulty swallowing. The other test we're going to talk about is the barium enema. The barium enema is used to identify structural abnormalities of the rectum and the colon. So what they're actually doing is using contrast dye, and they are looking to see if there is any kind of abnormalities or anything unusual. What you do need to instruct the patient in your nursing interventions include a clear liquid diet for 24 hours, and then the patient cannot have anything to eat or drink for 8 hours before the procedure. The patient does have to take laxatives. It just depends on the physician, but they may order an enema, laxative, or suppository. They have to take this the evening before. We do want the patient to have a clean colon, or you will not be able to see anything in there. You also need to tell the patient after the procedure they need to increase fluid intake. Take a laxative because they're using barium contrast dye, and we want to eliminate that from the bowel. And you also need to tell them that the stools may be white until the barium is completely emptied from the bowel. The next test, the next couple of tests are liver enzyme and ammonia. Those are blood tests that can be drawn. So just make sure that you review those. And then we're going to go ahead and just talk briefly about the liver biopsy. So with the liver biopsy, that is on page 575. The purpose and description is we're ruling out metastatic cancer, or they can also detect a cyst or cirrhosis of the liver. There's a picture of a liver biopsy, so it's showing you how they're using a needle to pierce in through and obtain a sample from the liver. For the nursing interventions, you need to make sure that the patient, if they're on any kind of anticoagulants, the physician needs to know, because it needs to be put on hold. With a liver biopsy, they're at a high risk of bleeding. So that is something you definitely have to monitor. The liver is super vascular, so it doesn't take much for it to rupture or for it to bleed. Food and fluids are withheld 4 to 6 hours prior to the procedure. You're doing baseline vitals. You would need to look at a PT or prothrombin time and platelet count. If you would need to administer vitamin K, it would be ordered. You do want to ask the patient to void before the procedure, because you don't want the bladder pushing up on the liver and displacing it slightly. The other thing is, after the needle is removed, pressure is applied, and the patient is put on their right side for 1 to 2 hours to maintain that pressure on the site. So you need to let them know they may experience some right shoulder pain. The dressing will be assessed frequently, and foods and fluids are withheld 2 hours after the biopsy. And that if the patient coughs, lifts, or strains, this needs to be voided for 1 to 2 weeks. So if they're coughing a lot, they definitely need some type of a splint, where you take the pillow and you double it over and you give them something to kind of hold on to cushion when they cough. But no lifting, no squatting, no straining for 2 weeks. And the patient is not allowed to drive home, because they do give them a sedation, and they usually just recommend rest for about 10 hours after the test. So that's a few of the GI tests. You guys can review over some of the rest of them that are in your textbook. There's quite a few, and for the most part, when you think of GI, they can do upper GI series or lower GI series. One of the lower GI series is the colonoscopy, which we didn't talk about, so make sure that you review that in your textbook. So we're just going to talk a little bit about the assessment as far as what I'm looking for you guys on a GI assessment. It goes over on page 577. It starts with the anthrometric assessment. I'm not going to get too hung up, and we're not going to practice that in lab. Just be aware of that there is something called the anthrometric assessment, and this is where you weigh the patient and measure the patient's height, and then you take a scale and you look and see what kind of normal range that they fall in based on small frame, medium frame, large frame. You guys will probably, if you are in some type of a clinic, or if you're doing like Winchester does Healthy You, so they do a lot of evaluations and screenings, they take these type measurements. So I'm not really going to go in depth, because for the most part you are not going to do this on a medical floor as a routine type GI assessment. So skip that part in your book, and then the next thing we go over to is page 578, and it's talking about calculating the BMI. You do need to know that there is a body mass index and some of what the normal range is. You do not need to know how to do the formula for your test. Just be aware that there is a formula to do, and that when we do assess a patient's BMI, it's important because we want to know if the patient is underweight, normal weight, overweight, or obese, because if you're doing patient education, that gives you something to go on depending on what you're talking about. So the other thing you can go ahead and mark off, something we're not going to do in lab, and I'm not going to test you on, is measuring the triceps skin fold. That is also on page 578. And then the other thing is the measuring the mid-arm circumference. So you can go ahead and mark that off out of your textbook. That takes you about to midway on page 579. So that brings us to about where we are right now. And when we start with the GI assessment, of course, we're going to start with the mouth, and the lips. Is it dry? Is it normal? Do we see any lesions? We look at the tongue. We look at the mucosa. We look at people's teeth. Do they have dentures? Do they have no teeth? Do they have a couple really bad teeth? We know that if a patient has an infection in your gums, that can be detrimental to the rest of your system because you can end up with a bacterial infection or sepsis. So some of the other things is looking at the saliva and the mouth. Is there stomatitis, which sometimes patients can get from chemotherapy, candidus, thrush in their mouth, especially patients that are in the hospital for long-term purposes and antibiotics. They can get thrush in the mouth. I like this diagram. It's in your textbook on page 580. It divides the stomach up into the 4 quadrants, and it also tells you what is housed in these 4 quadrants, and that's something that's important because if you have a patient who is saying that they have left upper quadrant pain, you're not thinking that, left upper quadrant pain is the bladder. You could be thinking, I know in the left upper quadrant, we could be thinking spleen, stomach, part of the kidney, but that's not really where you're going to have issues. If the bladder's distended, that's going to be the lower quads. The one thing that I do want to point out is that you do need to know that when we're talking about the abdominal assessment, the sequence is a little different. We have inspection, auscultation, percussion, and palpation. So make sure that you are reviewing box 21-2, which is the assessing the abdomen guidelines. One of the things that you also need to know is when you're inspecting, you're looking to see, is the abdomen skyphoid? Do you see any pulsations? When we're listening to the abdomen, you want to know that you need to listen for 5 minutes in all quadrants before you can confirm an absence of bowel sounds. You also need to know that when would you expect the bowel sounds to be hypoactive? Remember when we listen to the belly, we should hear a gurgle, gurgle. But sometimes it takes a little while to hear that. Well, if you have a patient who goes to the OR and they give them anesthesia, that slows down peristalsis, and they may not have that quick rumbling sound in their stomach compared to maybe somebody who is starving and hungry and you hear it like from the door instead of listening with your stethoscope. So percussion also plays a part into the abdomen. I made you guys a cheat sheet for the abdominal assessment that's posted under GI. You guys are also going to practice the GI assessment. There's certain components on there that I do want you to know. One of the things you need to know is tympany, and shifting dullness is a percussion technique that's important and why you're doing it. Palpating, you're always doing light touch. Rebound tenderness, you have the Kerr sign and Murphy sign. These are those crazy terminologies that the boards like to use. I can't tell you that you'll probably hear Murphy sign again, except maybe when you take your state boards, and then you probably never hear it again after that. So just make sure that you kind of make a note in regards to your book about some of those terms and what that means. And this is what you guys are going to go over also when you guys do your practice assessments. So this is a picture from your textbook. It's talking about the renal artery, iliac artery, and the femoral artery. We've talked about these in different areas of your assessment. I know it came up in cardiac, and there's the aorta also that you're looking at. You're listening, and you're listening for the bruit. You're looking for pulsations. Remember, you guys are not going to palpate or push down on the aorta, because if someone has a triple aneurysm, you can rupture it and they can die. So you're not going to go palpating and pushing down on all that. The other thing I just wanted to make sure that you know, on page 582, there is percussion of the liver. You guys are not going to percuss the liver. This is something that the nurse practitioner does and something that the physician does. And you do still see physicians percuss the liver. But it's not a technique that I'm going to teach you guys how to do as far as your routine GI assessment. So the other thing that you won't do is, we had already talked about percussing the spleen. And you guys are not going to percuss the spleen or the liver. You could do more damage than good from percussing it. So just one more added note and thing for you to take off of your list. You guys are not going to be doing a periannual assessment or digital examination. You may have patients that you may have to disimpact, and that's possible. And then you can always look then if you need to do an assessment. But as far as a thorough perianal assessment, you're not going to do a thorough one where you're going to glove up and you're going to be looking at everybody's rectum. That's not part of your routine GI assessment.